Respected examiner, I am presenting the case of Mr. Kanchikesi Nagapa, a 67-year-old right-handed illiterate male farmer from Davanagere, Karnataka. The history was provided by his son and is considered reliable. The patient presented with progressive difficulty in speech for 1 year and progressive difficulty in swallowing for 1 year. The patient was apparently normal 1 year ago when he developed difficulty in speech. The onset was insidious, and the illness has been relentlessly progressive since onset. Initially, he developed slurring of speech, which gradually progressed over the next 15 to 20 days to slow and strained speech. Within 1 month, he lost the ability to produce understandable words and could only make incomprehensible sounds, eventually progressing to complete anarthria. This was associated with progressive bilateral facial weakness, manifested by inability to close both eyes tightly, difficulty blowing out his cheeks and pursing his lips, inability to smile completely, leakage of liquids from both corners of the mouth while drinking, and pooling of food particles in the buccal vestibules after meals. At the same time, he developed difficulty in swallowing, which was also insidious in onset and gradually progressive. Initially, he had difficulty chewing and swallowing solid foods such as roti. Approximately 2 weeks later, he became unable to swallow semi-solid food like ganji because of nasal regurgitation and frequent choking episodes due to inability to clear throat secretions. Within 1 month, he developed difficulty swallowing liquids, and by the end of 3 months, he had difficulty swallowing even his own saliva. He was initially evaluated at local hospitals in Davanagere and was later referred to Manipal Hospital, Udupi, where he was managed conservatively and started on enteral feeding through a Ryle's tube. He has remained exclusively dependent on Ryle's tube feeding for the past 7 months. During the course of the illness, he also developed weakness of the limbs and neck. Initially, he noticed mild weakness of the right upper limb while lifting heavy objects weighing more than 5 kilograms, such as grain bags, which he was previously able to carry without difficulty. 3 months ago, he developed weakness of the neck extensors, resulting in a forward head drop, making it difficult to hold his head erect. Over the past year, his family has noticed progressive wasting of muscles involving all 4 limbs, associated with significant weight loss of approximately 20 kilograms. There is no history suggestive of diurnal variation in weakness. There is no history of ptosis, diplopia, or restriction of extraocular movements. There are no sensory symptoms such as tingling, numbness, paresthesias, or sensory loss. There is no history of difficulty performing fine motor activities such as buttoning clothes, combing hair, bathing, or mixing food. There is no history of difficulty climbing stairs, getting up from a squatting or sitting position, slipping of footwear, bowel or bladder disturbances, postural giddiness, excessive sweating, muscle cramps, or myalgia. There is no history of memory impairment, behavioral abnormalities, visual impairment, or hearing loss. His past history is significant for abdominal surgery performed 30 years ago and a minor head injury 1 year ago. He is a known case of benign prostatic hyperplasia diagnosed 3 months ago and is currently on tablet tamsulosin with dutasteride once daily. He consumes a vegetarian diet with eggs. His appetite is preserved, although his sleep has been disturbed over the past 1 year. There is no history of tobacco or alcohol use. Family history reveals second-degree consanguinity, with his parents being cousins. There is no family history of similar neurological or neuromuscular illnesses. On general physical examination, the patient is conscious, cooperative, and well-oriented to time, place, and person. He is poorly built and severely malnourished. His height is 160 centimeters, weight is 38 kilograms, and body mass index is 14.84 kilograms per square meter. His pulse rate is 82 beats per minute, regular with normal volume and character. Blood pressure is 130 by 80 millimeters of mercury measured in the right upper limb in the supine position. Respiratory rate is 18 per minute with an abdominothoracic pattern, and oxygen saturation is 98% on room air. There is no pallor, icterus, cyanosis, clubbing, or lymphadenopathy. Bilateral pitting pedal edema extending up to the mid-leg is present, likely secondary to severe malnutrition with hypoalbuminemia. On higher mental function assessment, the patient scored 30 out of 30 on the Kannada Mini Mental State examination. Comprehension is intact. Formal assessment of language could not be performed because of complete anarthria, although there is no clinical evidence to suggest aphasia. On cranial nerve examination, olfaction is intact bilaterally. Visual acuity is 6 by 6 in both eyes with normal visual fields and normal fundus examination. The 3rd, 4th, and 6th cranial nerves are normal with no ptosis, full extraocular movements, normal saccades and pursuits, and bilaterally equal pupils measuring 2 millimeters reacting normally to light and accommodation. The trigeminal nerve examination reveals intact facial sensations bilaterally. Motor examination shows weakness of the muscles of mastication, including the masseter and pterygoids, evidenced by weak jaw closure and weak lateral jaw movements. The jaw jerk is exaggerated. The facial nerve examination demonstrates bilateral upper and lower motor facial weakness, with weak forehead wrinkling, incomplete eye closure against resistance, flattened nasolabial folds, and weakness of orbicularis oris. Taste over the anterior 2/3 of the tongue is preserved, and corneal and conjunctival reflexes are intact. The vestibulocochlear nerve examination is normal with preserved hearing bilaterally. Rinne's test shows air conduction greater than bone conduction bilaterally, and Weber's test is central. Examination of the glossopharyngeal and vagus nerves shows symmetrical but reduced palatal movements with an absent gag reflex. The accessory nerve examination reveals bilateral weakness of the sternocleidomastoid and trapezius muscles. Examination of the hypoglossal nerve shows marked tongue atrophy with widespread fasciculations. Tongue tone and power are reduced, although the tongue can be protruded in the midline without deviation. Motor system examination reveals diffuse wasting involving the temporalis, masseter, bicep, triceps, quadriceps, hamstrings, and intrinsic muscles of both hands. Muscle tone is normal in all four limbs. Power is reduced in the neck flexors, neck extensors, spinal extensors, and abdominal muscles. In the upper limbs, proximal muscle power is 3 out of 5 bilaterally. Elbow flexors and extensors are 4- out of 5, while distal muscles retain normal power of 5 out of 5. In the lower limbs, proximal muscle power is 3 out of 5 bilaterally, whereas distal muscle groups have preserved power of 5 out of 5. Superficial abdominal reflexes are present bilaterally, and plantar responses are mute bilaterally. Deep tendon reflexes are exaggerated throughout. Jaw jerk is brisk. Biceps, supinator, triceps, pectoralis, knee, and ankle jerks are all graded as 3+ bilaterally. Hoffman's sign and finger flexion reflex are present bilaterally. Clonus is absent, and frontal release signs, including glabellar tap, palmomental, snout, and rooting reflexes are absent. Sensory examination is entirely normal. Fine touch, crude touch, pain, temperature, vibration, joint position sense, and cortical sensory functions are intact. Cerebellar examination is normal with no nystagmus. Finger to finger to nose, rapid alternating movements, and heel to shin testing are normal. Romberg's test is negative. Gait could not be adequately assessed because of severe proximal weakness and poor nutritional status. There are no meningeal signs, and examination of the skull and spine is unremarkable. In summary, this is a 67-year-old gentleman with a 1-year history of relentlessly progressive bulbar dysfunction, presenting with dysarthria, progressing to complete anarthria, severe dysphagia requiring prolonged Ryle's tube feeding, bilateral facial weakness, neck weakness with head drop, proximal limb weakness, diffuse muscle wasting, and significant weight loss. Neurological examination demonstrates lower motor neuron signs in the form of tongue atrophy, tongue fasciculations, muscle wasting, and weakness, together with upper motor neuron signs, including exaggerated jaw jerk, generalized hyperreflexia, and bilateral Hoffman sign. Sensory, cerebellar, autonomic, extrapyramidal, and higher cortical functions are preserved. The anatomical localization is to the anterior horn cells of the spinal cord and the motor nuclei of the lower cranial nerves in the brainstem, accounting for the lower motor neuron features, along with involvement of the corticospinal and corticobulbar tracts, accounting for the upper motor neuron signs. The pathological localization is a chronic progressive neurodegenerative disorder selectively affecting the motor neuronal pathways. My final clinical diagnosis is definite amyotrophic lateral sclerosis with Bulbar-Onset, fulfilling the revised Ellis-Coriell criteria, with electrophysiological confirmation expected as per the Awaji criteria. The important differential diagnoses include Bulbar-Onset myasthenia gravis, cervical compressive myelopathy or craniovertebral junction anomalies, structural brainstem lesions, Kennedy disease or spinobulbar muscular atrophy, multifocal motor neuropathy, progressive muscular atrophy, and primary lateral sclerosis. This version is arranged in the sequence expected during a DM Neurology long case presentation and is written in a smooth narrative style suitable for reading directly to the examiner. Question: why did you mention that the speech difficulty was progressive? Answer: a progressive course suggests a neurodegenerative, neoplastic, or chronic inflammatory disorder, rather than a vascular or metabolic cause. In this patient, the relentless progression favors a neurodegenerative disorder such as amyotrophic lateral sclerosis, ALS. Question: what exactly do you mean by speech difficulty? Answer: speech difficulty can result from dysarthria, dysphonia, aphasia, or apraxia of speech. In this patient, it is dysarthria progressing to complete anarthria due to weakness of the bulbar muscles. Question: how will you differentiate dysarthria from aphasia? Answer: dysarthria is a motor speech disorder caused by weakness or incoordination of the speech muscles while language is preserved. Aphasia is a disorder of language affecting comprehension, expression, naming, repetition, reading, or writing. This patient has preserved comprehension with severe motor speech impairment, favoring dysarthria. Question: what are the causes of dysarthria? Answer: dysarthria may result from upper motor neuron lesions, lower motor neuron lesions, cerebellar disorders, basal ganglia disorders, neuromuscular junction disorders, muscle diseases, or mixed lesions such as ALS. Question: what is anarthria? Answer: anarthria is the complete inability to articulate speech due to severe paralysis of the muscles involved in speech despite intact language function. Question: why is dysphagia important in this patient? Answer, dysphagia indicates bulbar involvement. Its progression, along with dysarthria, strongly suggests involvement of the lower cranial nerves or corticobulbar pathways. Question, how do you classify dysphagia? Answer, dysphagia is classified into oropharyngeal dysphagia and esophageal dysphagia. This patient has oropharyngeal dysphagia. Question, why do you say this is oropharyngeal dysphagia? Answer, because the patient has difficulty initiating swallowing, nasal regurgitation, choking, aspiration, and pooling of food in the mouth, which are classical features of oropharyngeal dysphagia. Question, what neurological disorders cause oropharyngeal dysphagia? Answer, amyotrophic lateral sclerosis, myasthenia gravis, brainstem stroke, brainstem tumors, bulbar palsy, pseudobulbar palsy, inflammatory myopathies, muscular dystrophies, and Parkinson plus syndromes. Question, why did you ask about diurnal variation? Answer, to exclude myasthenia gravis, where weakness typically worsens with activity and improves with rest. This patient has no diurnal variation. Question, why did you ask about ptosis and diplopia? Answer, ocular involvement is common in myasthenia gravis, but is usually absent in ALS. Their absence favors ALS. Question, why did you ask about sensory symptoms? Answer, ALS selectively affects motor neurons, so sensation remains normal. Sensory symptoms would suggest neuropathy, myelopathy, or another neurological disorder. Question, why did you ask about bowel and bladder symptoms? Answer, bowel and bladder functions are usually preserved in ALS. Their involvement would suggest spinal cord pathology or another neurological disease. Question, why did you ask about autonomic symptoms? Answer, autonomic involvement suggests disorders such as multiple system atrophy, autonomic neuropathy, or spinal cord disease rather than ALS. Question, why did you ask about cognitive decline? Answer, although ALS may occasionally be associated with frontotemporal dementia, the absence of cognitive impairment supports isolated motor neuron disease. Question, why did you ask about family history? Answer, approximately 5 to 10% of ALS cases are familial. Family history also helps identify hereditary motor neuron disorders such as Kennedy disease. Question, why did you ask about consanguinity? Answer, consanguinity increases the likelihood of inherited neurological disorders, although classical ALS is usually sporadic. What is the significance of severe weight loss? Answer, it results from progressive muscle wasting, severe dysphagia causing poor nutritional intake, and the hypermetabolic state associated with ALS. Question, what is the significance of head drop? Answer, head drop indicates weakness of the neck extensor muscles and is seen in ALS, myasthenia gravis, inflammatory myopathies, and isolated neck extensor myopathy. Question, why are fasciculations important? Answer, fasciculations indicate lower motor neuron involvement due to spontaneous discharge of diseased motor units. Tongue fasciculations are particularly characteristic of ALS. Question, what is the significance of tongue atrophy? Answer, tongue atrophy indicates lower motor neuron involvement of the hypoglossal nucleus or nerve and strongly supports Bulbar-Onset ALS. Question, why is the jaw jerk exaggerated? Answer, an exaggerated jaw jerk is an upper motor neuron sign indicating corticobulbar tract involvement. Question, what is the significance of brisk deep tendon reflexes despite muscle wasting? Answer, the coexistence of lower motor neuron signs with generalized hyperreflexia is characteristic of ALS because both upper and lower motor neurons are affected. Question, why is Hoff sign positive? Answer, Hoffman's sign is an upper motor neuron sign indicating corticospinal tract dysfunction. Question, why are plantar responses mute? Answer, mute plantar responses may occur despite corticospinal tract involvement and do not exclude ALS. Question, why are extraocular movements normal? Answer, ocular motor nuclei are relatively spared in ALS. Early ophthalmoplegia would suggest alternative diagnoses such as myasthenia gravis or progressive supranuclear palsy. Question, what is the anatomical localization? Answer, the lesion localizes to the anterior horn cells of the spinal cord, motor nuclei of the lower cranial nerves in the brainstem, corticospinal tracts, and corticobulbar tracts. Question, what is the pathological localization? Answer, it is a chronic progressive neurodegenerative disorder selectively affecting upper and lower motor neurons. Question, what are the cardinal clinical features required for diagnosing ALS? Answer, evidence of upper motor neuron degeneration, lower motor neuron degeneration, progressive spread of symptoms, and exclusion of alternative diagnoses. Question, What are your differential diagnoses? Answer: bulbar-onset myasthenia gravis, cervical compressive myelopathy, brainstem structural lesions, Kennedy disease, spinobulbar muscular atrophy, multifocal motor neuropathy, progressive muscular atrophy, and primary lateral sclerosis. Why is this not myasthenia gravis? Answer: there is no fatigability, no diurnal variation, no ocular involvement, definite tongue wasting and fasciculations are present, and there are clear upper motor neuron signs. These findings question favor ALS. Why is this not Kennedy disease? Answer: Kennedy disease presents with lower motor neuron signs without upper motor neuron signs and is often associated with gynecomastia, testicular atrophy, and endocrine abnormalities, which are absent in this patient. Question: why is this not multifocal motor neuropathy? Answer: multifocal motor neuropathy causes asymmetric distal limb weakness with conduction block, has no bulbar involvement, and lacks upper motor neuron signs. Question: what is your final diagnosis? Answer: definite amyotrophic lateral sclerosis with bulbar onset involving both upper and lower motor neurons, fulfilling the revised L-Escorial diagnostic criteria with electrophysiological confirmation according to the Awaji criteria. If you're preparing for a DM Neurology long case, in a DM Neurology examination in this patient, answer: like stroke, less likely. Yes. The patient was apparently normal 1 year ago and gradually developed slurring of speech without any identifiable precipitating event. An insidious onset favors a chronic neurodegenerative disorder such as ALS and makes acute conditions like stroke less likely. Question: what is the progression of illness? Answer: the illness has been slowly progressive and relentless without any periods of improvement or fluctuation. Speech progressively worsened from slurring to complete anarthria, dysphagia, progressed from solids to liquids and finally saliva, and later proximal limb and neck weakness developed. This pattern is characteristic of ALS. Question: has the disease reached its peak? Answer: no. The disease has not reached its peak. The symptoms have continued to worsen over the past year without stabilization or recovery. ALS is a continuously progressive neurodegenerative disease, so the patient is still progressing. Question: what is the importance of the onset being insidious? Answer: an insidious onset suggests a chronic disease process, such as a neurodegenerative disorder, chronic compressive lesion, or slowly growing tumor. It argues against acute vascular disorders, infections, or toxic metabolic causes. Question: what is the importance of the slow progressive course? Answer: a slow progressive course strongly favors motor neuron disease, particularly ALS. It also helps differentiate ALS from disorders such as stroke, Guillain-Barré syndrome, metabolic disorders, and functional neurological disorders. Question: why is it important to know whether the disease has reached its peak? Answer: knowing whether the disease has reached its peak helps classify the disease pattern. If symptoms reach a peak within hours, think of stroke. If they peak over days to 4 weeks, think of Guillain-Barré syndrome. If they fluctuate with improvement, think of myasthenia gravis. If they relapse and remit, think of multiple sclerosis. If they progressively worsen without reaching a peak, think of ALS or another neurodegenerative disorder. Question: how does this patient's disease pattern support ALS? Answer: this patient has an insidious onset, continuous progression, no fluctuations, no remissions, and no peak even after 1 year. This is the classical temporal profile of amyotrophic lateral sclerosis. For Viva purposes, you can summarize it in one sentence. Open quote: this patient has an insidious onset, a slowly progressive and relentlessly worsening course, and has not yet reached the peak of illness. This temporal profile is highly suggestive of a chronic neurodegenerative disorder, particularly bulbar onset amyotrophic lateral sclerosis. Close quote.